Observation is arguably one of the top talents that any physical therapist possesses and can give the clinician, the skilled clinician, just a boatload of information if done with intention and with a keen eye. And so when you're dealing with someone who's complaining of lumbosacral pain or symptoms, one of the things that you want to do is, as you're watching them go through some of their initial range of motion screens and assessments, is be watching for certain clues that may allow you an opportunity for pattern recognition. And so for this video, we're going to be talking about some of the observational aspects of lumbosacral assessment. And again, these are done as part of the initial screen when you're going through active range of motion. So let's go ahead and dive right in. We're going to have our patient turn and face us for this. We want to standardize our setup, so we're going to bring our foot and have them align their heels on our foot. Then from this position, the first thing we're going to do is we're going to ask them to go into flexion. Now there's a separate video where we actually look at active range of motion and kind of a planar based approach for that. I'll link that for this video, but for this video we're specifically looking just from an observational standpoint. So as we have the individual go into flexion and forward bend, we're looking for the smoothness of that motion. And if there's any kind of instability, that may be potentially impacted. Additionally, folks who have instability of the lumbosacral spine tend to have a lot of mobility, and so we may see that our patient is able to actually put their hands flat on the ground or touch their toes. As they come back up though, it may not be smooth, there may be a little pause, and then they can come back up, and that's where they're kind of getting around potentially an instability or an irritable segment. Or one of the other things we may see is as they come back up, they actually have to climb their way back up on their thighs to get to that upright posture, and that's something known as a Gower sign, okay? It is correlated with individuals who have instability or may have some other form of pathology to the lumbosacral spine. One of the other things that we can look at then is some differences in lumbosacral pelvic rhythm. And so with this, we're going to demonstrate this recognizing that our patient here doesn't really have these variances, but we're going to ask them to kind of mimic them. So the first one is where the lumbar spine really doesn't flex and all the mobility comes from the pelvis and the extensibility of the hamstrings. So we're going to ask our individual to kind of maintain an extended posture and then flex forward as far as they can. Now you'll notice after seeing his range of motion just a moment ago, there's not a lot there, right? So all of the range of motion is coming from the extensibility of the hamstrings, which palpating are very tight, as well as that anterior tilting of the pelvis, right? Go ahead and come back up. Now the second variation is where all of the motion comes from the lumbar spine, but really there's no anterior tilt of the pelvis. So we're going to ask the individual to posterior pelvic tilt. Perfect. And then flex forward as far as they possibly can just through the lumbar spine. And you'll notice again, we get a little bit of that kyphotic posture through the thoracic spine, a little bit of flexion through the lumbar spine, but there's not a whole lot of mobility because they're restricting through the pelvis and through that posterior chain. Finally, our third pattern is when all of it works in unison together. So go ahead and bend forward as you normally would at this point. We see nice flexion through the thoracolumbar spine. We see anterior pelvic tilt. The posterior chain is still having to work with regards to extensibility, but now all of that working together gives us our full and total functional range of motion. Go ahead and come back up. So as you're working with your patient, be looking for these, and specifically we're kind of looking in the frontal plane. One other thing, go ahead and turn to the side here, is when we are in the sagittal plane, sometimes you will see your patients kind of shifted a little bit. They're off kilter, and that may be because they have an area where they're dealing with an impingement due to a disc pathology or a facet arthropathy. And so you'll see that then in the sagittal plane, the top half is not aligned with the lower half. It can almost look like a scoliosis. And so you'll want to assess to ensure that you're not dealing with some type of morphologic change in the spine, and rather this is flexible and you can adjust it. The last piece then that we want to look at in this sagittal plane is as we bend forward again to touch our toes, if there is a facet arthropathy or a disc pathology or some other form of mechanical irritation, as the individual comes up slowly, they may try to kind of get around that by almost creating a little bit of a C or an S-shaped curve as they come back to that neutral position. And so again, emphasizing the importance of looking not only from the side, but also straight on to ensure you're capturing all of the relevant information while making the assessment of mobility. So have a go with these observational techniques with a peer, a colleague, and let me know if there's any questions.